So I think one of the real critical aspects to performing laparoscopic inguinal hernia repair in a safe and effective manner is to first understand the preperitoneal anatomy. The preperitoneal anatomy is something that I think most general surgeons in their training, certainly if they trained more than a decade ago, did not get a lot of experience in terms of their understanding. So the preperitoneal anatomy is something that's often foreign to many general surgeons. In order to be able to perform a laparoscopic inguinal hernia repair, understanding the anatomy is really the first task for the surgeon. And this demonstrates the anatomy, obviously an inanimate model. So if we kind of start inferiorly and work superiorly, the bladder would sit here just below Cooper's ligament, which is going to run from medial to lateral. The pubic tubercle is here, and this would be Cooper's ligament. The posterior aspect of the rectus muscle here is going to be the medial aspect of the dissection, and the medial aspect of the anatomy that we're going to be interested in. The next important anatomic landmark would be the iliopubic tract, extending from the pubis out to the anterior superior iliac spine. And this is important because all of the critical structures that we want to avoid in terms of fixation, tacking, suturing the mesh in place lie below the iliopubic tract. And below the iliopubic tract, we're going to see from medial to lateral the vas deferens entering the internal ring as it comes up here from kind of a medial to lateral approach. The testicular vessels, which you can see here lying over the iliacs, again entering the internal ring. Deeper and a little bit more lateral are going to be the iliac vessels, the vein, and then the artery more laterally. From the standpoint of postoperative pain, nerves come into play. The genitofemoral nerve, which runs along the psoas muscle, and the genital branch, which enters the internal ring here, along with the testicular vessels, and then more laterally, the lateral femoral cutaneous, which supplies sensation to the anterior lateral thigh. These are going to be the nerves and the vessels that we don't want to injure when we're either doing our dissection or when we're fixating the mesh. Above the iliopubic tract, the epigastric vessels are going to separate the more medial direct space from the more lateral indirect space. Just below and medial is going to be the femoral space, and this would be the location of a femoral hernia. So I think the real advantage of a laparoscopic inguinal hernia repair is that it allows us to repair a direct inguinal hernia, an indirect inguinal hernia, a femoral hernia, or even an obturator hernia, which would exist here in the obturator space with one piece of mesh and with one technique. So all hernias of the myopectoneal orifice or of the groin are going to be approached potentially by a laparoscopic approach. Obviously that would involve placing a large prosthetic in the retromuscular space so that we can cover all of those potential defects.